the background is that we know from randomized controlled trials, as well as from real-world evidence, that prostate cancer screening using the PSA test leads to a reduction in prostate cancer mortality with up to about 40%. However, despite these results, no country has instituted an organized prostate cancer screening program except for Lithuania. And the reason for that is that prostate cancer screening using the PSA test also leads to a lot of harm in terms of overdiagnosis of indolent prostate cancer that wouldn't cause harm in the patient or lead to prostate cancer death. And it also leads to a lot of unnecessary biopsies in perfectly healthy men, which increases the risk of severe infections, etc. So in order to really get to the benefit of prostate cancer screening, we need to reduce these harms. And over the last about 15 years or so, a few tools have been developed for doing that. So one is to use multivariate risk prediction models for predicting a man's risk and combining a lot of information except the PSA test or on top of the PSA test to get a better understanding for who's at risk of having clinically significant prostate cancer. The other such tool that has been developed over the last few years is really magnetic resonance imaging, or MRI, which has made its introduction into prostate cancer early detection and diagnosis over the last few years. And both of these tools have shown strong promises to reduce these harms of overdiagnosis and unnecessary biopsies. But there hasn't to date been evidence for the use of these tools in a population-based organized sort of screening setting. And that is what we do with the Stockholm 3 MRI trial. We test these two tools in concert together in a population-based organized screening setting. So that's really the background and why we decided that this trial is necessary and important. So what we did in the Stockholm 3 MRI trial was that we invited men from the general population to undergo prostate cancer screening. So it was a prospective randomized population-based screening by invitation trial, essentially, which was conducted in men of the age of 50 to 74. And the Stockholm 3 MRI trial uses a slightly, or actually a new design. So it uses two steps. The first step is what we call the pair design, where we test the ordinary standard PSA test with multivariable risk prediction in the form of the Stockholm 3 test in the Stockholm 3 MRI trial. And if you were positive on either of these two tests, you proceeded to a randomized step where men were randomized to either undergo standard systematic 10 to 12 core biopsy or MRI, and then targeted biopsies plus systematic biopsies if the MRI was suggestive of prostate cancer, whereas the men who were negative on the MRI didn't undergo biopsy. And the reason for having these two steps is that in the first step, we can compare the two tests within the same man, and that reduces variance and therefore also increases statistical power without really risking the introduction of any bias. But in the randomized step, we needed to do the randomization to ensure that, we wouldn't introduce bias of testing the same or different biopsy procedures within the same man. So therefore we needed to come up with this sort of design where we used first a paired step and then a randomized step. And the MRI that we used was a biparametric, quite short program. So it was designed without any contrast enhancement or endorectal coil. And it was designed that way in order to make it amenable or possible to introduce in a high volume screening setting. So that's also one of the key features, I think, of this trial, that the MRI is designed to be able to be used in a high volume setting. So this design altogether sort of constructs an analytical framework where we can compare and contrast and test different types of or different screening methods for prostate cancer using Risk prediction here in the Stockholm 3 MRI trial using the Stockholm 3 algorithm and the PSA test, and we can compare MRI and targeted biopsies with standard systematic biopsies, and any combination of these two methods. So therefore we can actually come to test a lot of different screening strategies, and that's what we're going to do also in upcoming manuscripts from this trial. So the key findings that we have published so far in the New England Journal of Medicine last week was that we showed that by using MRI and targeted plus systematic biopsies in men who had positive findings on the MRI, by doing those biopsies compared instead of doing systematic biopsies on all men who were positive on the PSA test, we could reduce the number of detected indolent or clinically insignificant prostate cancers by about 2/3, and also the number of unnecessary biopsies by up to 70%. So this was done without compromising the detection of clinically significant prostate cancers, the ones that has the potential to really cause prostate cancer mortality. So in essence, the results show that we can address the main barrier for implementing organized prostate cancer screening by using MRI and using only targeted and systematic biopsies in the men who were positive on the MRI. Yeah, thank you for that question. I think that's of course really perhaps the key or the most important question is how do we take these results and move them into something that is clinically actionable. And I think that what I really hope with these results is, of course, that they can help with the introduction of organized prostate cancer screening programs in hopefully several different countries. And because we know today that we have in many countries rather chaotic, opportunistic screening going on for prostate cancer, and this has been shown over and over again to be quite inefficient, and also that a lot of PSA testing is conducted in, for instance, elderly or frail men who don't really benefit from PSA testing. So I strongly believe that organization will help and will lead to better prostate health in men. So if we can take these results and if they can help with moving towards organization and like a similar kind of idea that we have for mammography screening, for instance, in many countries of the world, I think that would really be fantastic. And showing these results that we can reduce the number of clinically insignificant cancers by about 2/3 and the number of unnecessary biopsies by about 70%. I think that this provides very strong evidence for moving forward towards more organization. So that's really what I hope. And for instance, in Sweden, where the trial was conducted, we are currently investigating moving towards organized prostate cancer screening. And if this can help with that, I think that would be fantastic, and hopefully we can help men to better prostate health in the future. The key thing here to mention is perhaps that the Stockholm 3, as I said before, the Stockholm 3 MRI trial is sort of a rather, not perhaps complex, but still it enables or makes it possible to compare several different ways of performing early detection for prostate cancer. And the results that we have published so far is when we compare standard systematic biopsies to MRI and targeted biopsies. But we will, in upcoming publications, also show results from others different ways of doing prostate cancer screening. So we showed in an abstract that was presented at the EAU conference just last week that by using risk prediction, we can also reduce MRI utilization in preliminary results. And that is really, I think, a key component here as well, because we know that by using MRI, it creates a rather complex diagnostic chain where we need high quality in both the MRI and the interpretation of the MRI done by radiologists who need to be well trained. And if we can reduce MRI utilization, that will likely lead to reductions in cost of doing prostate cancer screening in it, and hopefully create a rather or a somewhat simpler and easier to implement diagnostic chain. So that's something that we'll show in upcoming publications that hopefully will be published in the next month or two, where we can show how risk prediction can really lead to a reduction in MRI utilization. And we also have upcoming publications where we'll look at the health economy of doing all of this. So there's a lot to be looking forward to here, I think, with upcoming results from this trial. So that's very exciting, I think.